Dear colleagues, dear chairman, thank you very much for giving me the opportunity to present this work about therapeutic escalation in neurogenic diffuser overactivity in patients suffering from spinal cord injury. It is a Bicentric study, a real-life experience. As you all know, the main goal of neurogenic diffuser overactivity management following spinal cord injury is first to improve patients' quality of life with avoiding urinary incontinence, but also to avoid high diffuser pressure to prevent renal failure. This management is well standardized with first antimuscarinics and then onabotulinum toxin A in case of failure. In case of failure of these two first therapeutic line, surgical procedure will be proposed to these patients. To our best knowledge, any study described the therapeutic escalation in spinal cord injury patients suffering from neurogenic diffuser overactivity. As a result, to answer to this question, we designed a Bicentric retrospective study in which patients with recent spinal cord injury and with a follow-up of 10 years were included from two big rehab centers in France. We recorded clinical and urodynamic data, but also the different therapeutic line to assess their failure. Failures were defined either with reappearance of urinary incontinence or with reappearance of high intradiffuser pressure of low bladder compliance at urodynamic. We performed survival curve to assess the duration of this different therapeutic line. In this study, we included 105 patients, mainly young male with complete lesion. Within the first year of this follow-up, 70% of these patients were treated with antimuscarinics. We noticed that only 44% of these patients remain responder to antimuscarinics 5 years after their introduction, leading to the failure of this first-line therapy. 7 years after the lesion, 55% of these patients underwent to onabotulinum toxin A, often associated with antimuscarinics. As previously described in several studies, we also noticed a failure of this second therapeutic line after several years. As a result, this study is the first one to describe in a large cohort of patients suffering from spinal cord injury the management of neurogenic diffuser overactivity, underlining the midterm efficacy of the two first therapeutic line to manage these patients. As a result, a regular follow-up is mandatory in these patients who may fail to be controlled by these two first therapeutic line. And moreover, an improvement of non-surgical therapy is needed or the development of new one in order to improve the management of these patients. Thank you very much for your attention.
I have a question. At what time did you start using Botox for these patients?
What time did I?
What time did your institution start using Botox?
Actually, we started to use Botox after the confirmation of the failure. The failure was confirmed after either the reappearance of urinary incontinence or the urodynamic data, and two examinations has to be done to confirm this reappearance. So in our center, it was very depending on the patients, but in this study, it was 7 years after the spinal cord lesion.
But at what year at what year did you start using Botox as a treatment?
From the beginning, actually, we are in the pilot study. Yeah.
Okay.
Sorry,
but,
I didn't understand.
But that time was not licensed, right?
Sorry.
So this was off license at the beginning and then licensed later.
Yeah.
Just a really quick question, very simple one. In France, do you centralize the care of spinal injury patients to a small number of units?
Actually, in France, there are several big units of rehabilitation who manage this kind of patients. We worked with Nantes, which is one of the big centers, as we can be in France. So actually, there are only 2 or 3 big centers who manage this kind of patients. That's why we are a lot of patients and we can perform this kind of study.
And do you consider using Botox in combination with antimuscarinics, or is it only pure Botox, pure antimuscarinics?
Actually, we published 3 years ago a study to analyze our way to treat our patients, and 70% of these patients were treated with both. So,
right.
In our practice, we decide to still give some antimuscarinics when we introduce Botox, and then depending on the patients, we can take off some antimuscarinics.
And this is based on symptoms, for example, urinary incontinence, or based on urodynamic findings?
Both, actually both.
And there's a new drug, the beta-3 agonist. Do you use those as well, maybe in combination?
No, not in this kind of patients. Regarding the recent literature, we do not have enough proof to demonstrate the efficacy in spinal cord injured patients, especially for high distributor pressure.
Okay. Is there any question from the audience? There's one more question. You may tell your name and your institution.
I'm Elizabeth Farrelly from Stockholm in Sweden. I've been working for quite a few number of years with the Spinal Cord Injury Center in Stockholm, but I'm a urologist. I may have missed it, but you mentioned something about failure when you moved from anticholinergics to the use of Botox, and you mentioned that the introduction of Botox was done because of failure. So how do you define failure? What made you move on to another form of therapy? Because failure in managing the neurogenic bladder is a big and difficult topic.
Yes, it is. So we use the same criteria we already used in former studies. So as I told, it was both criteria. The first one is clinical, so with reappearance of urinary incontinence, which will decrease patients' quality of life. So according to us, it is an aspect of failure of this therapy. And the second one is urodynamic criteria with high distributor pressure above 40 centimeters of water or low bladder compliance under 20. So it was either one or another one or the two in the same time.
And as I'm sure you know, we will probably have a lot of days in the future where we will discuss these levels of 40 centimeters of waters and compliance below 20, etc., because these are really difficult concepts at the moment.
Yes, it is. Thank you.
So thank you very much.
Thank you too.
Thank you very much for your presentation.